from part of this world, so I can safely say good afternoon. And today we are starting a webinar. This webinar is actually I am sending all the messages to different WhatsApp group of AATM. And good part is that this webinar topics, these are out of the box. You know, it's not the routine how to increase repeat voluntary blood donation and others. And all these three topics, because one of the speakers she is going to talk on how do I ensure safe blood donation during disease outbreak. You know the problem we had, like COVID. And you cannot say that there will not be any other pandemic coming in sometime near future. Of course, second is another problem, routine problem with us. Those are re-entry of the false positive, especially when you do sensitive tests like NET testing. And sometimes patients are positive, donors are positive. And there are some special situations, sometimes you say positive, donor is deferred. This donor goes to another blood bank or another place, get tested, and comes and just bang on you. You are saying positive, there I'm negative, what to do? And if it's especially a voluntary donation. So thank you, Dr. Mehta. You have included that topic, this burning problem for blood bankers. Third is another problem. This problem was probably not there in this part of this world, maybe around 5 or 10 years back. The donation by the third gender, it's a new one. Now this LGBT community, they are recognized by the court of law in many countries, and they are recognizing third gender as a gender. Therefore, whether to take blood donation from third gender, and country rules are different. Like recently, one paper is going to be published in this month of Dr. Nidhi and mine. That will be whether third gender can donate or not. It depends upon the regulation in the country. So without taking your much time, thank you, Dr. Mehta. You have given me the time to speak to the speaker. After this, I'm here, but Dr. Mehta is going to steer the whole session. Thanks to all the three speakers, as well as thanks to all other participants. And we feel there will be more participants joining. One special thanks to Dr. Irina Safari. She's actually joining from Albania. So thanks to all participants, and over to Dr. Mehta. Thank you.
Thank you, Dr. Chaudhary. Good evening and good afternoon, everybody. And thank you for joining us today, and welcome to blood donor screening in challenging situation. I am Dr. Mahtab Maksudlu from Voluntary Blood Donation Group of AATM and Deputy of Research and Education of Iranian Blood Transfusion Organization, or IBTO. This webinar is focused on challenging blood selection criteria that is an important topic because affect both blood supply availability and blood safety. And we organized this webinar to share what we know and ask answer the question you may have. Before we start, I would like to inform you, if you have any question, you can share by by chat box, and then in the panel discussion, we try to answer your question. And first of all, I would like to invite Dr. Amita Krishna to talk for us about how do I ensure safe blood donation during disease outbreak. Dr. Amita is a pathologist, and she worked as an assistant professor in Department of Transfusion Medicine of Sri Chitra Institute for Medical Science and Technology in Kerala of India. Dr. Amita, please.
Thank you very much, madam. Shall I start my presentation?
Please go ahead, Dr. Amita.
So good afternoon, everyone. I'm Dr. Amita from Trivandrum, India. And thank you, madam, for the introduction also. So my topic is, how do I ensure safe blood donation during disease outbreaks? So as transfusion medicine physicians, our prime responsibility lies in being able to provide safe blood to our patients and also maintain a sufficient stock of safe blood in our inventory. So this is a map that is taken from the US Center for Disease Control website. And this map shows the significant disease outbreaks that had occurred in different parts of our world during the last 2 decades. And certainly the numbers are going to increase in the coming years. So the future of humanity and microbes likely will unfold as episodes of a suspense thriller that could be titled Our Wits versus Their Genes. So in this fight against these emerging pathogens, the only thing that is going to safeguard us is our preparation. So I hope this presentation will go a long way in getting us prepared to face the pandemic situation. So first of all, we will try to see what is the difference between an outbreak, an epidemic, and a pandemic. So an outbreak is defined as a sudden rise in the occurrence of a disease in a specific community in excess of what is expected in a defined area during a specified time period. So even a single case of an infection, which was not previously reported in that locality, is enough to declare it as an outbreak. Next is epidemic, the rapid spread of disease over a large topographical area in excess of what is normally expected is called an epidemic. And pandemic is an epidemic that has spread over multiple continents. So this is just for illustration. Even a single case which was not previously reported or which infection was not previously reported in an area, you can call it as an outbreak. For example, recently we had a Nipah outbreak in Kerala. Then when the infection affects a larger number of the population or spreads into a larger geographical area, you call it as an epidemic. And when it spans over multiple continents, it becomes into a pandemic. So this is another quote. A shrinking globe puts pathogens from the sub-Saharan rainforest within 24 hours of a blood center in the plains of North America. And I think this is very true because in this era of shrinking world, we are becoming one global village. So any infectious outbreak occurring anywhere in the world has the potential to spread into an epidemic and a pandemic. So what are the implications of these infectious threat on the blood transfusion services? So we have to ask ourselves some questions. Is this infectious agent present in the so-called apparent healthy asymptomatic donor population? If yes, is the infectious agent likely to be present in the donated blood? If yes, if the infectious agent is likely to be transfusion transmitted to the recipients, that means whether this infectious agent can survive our processing techniques, will escape our screening assays and medical examination. Then if the answers to all these questions is a yes, and we have not prepared ourselves well, then this infectious agent can or is likely to contaminate the blood inventory. The second scenario is if the infectious agent is unlikely to be transfusion transmitted, but it is likely to cause significant morbidity and disease in the healthy donor population, then the number of donations are going to get reduced, and that will adversely impact the inventory, or that will adversely affect the blood stock sufficiency. So these are the two ways in which any infectious threat threatens the blood transfusion services. One, it can make the blood unsafe, or it can affect the blood stock sufficiency. So if the infection is going to affect the blood safety, our prime concern will be on minimizing the risk of infected donations entering into the inventory. And if the stock is the one that is likely to be suffering, then we have to actually assess the situation very carefully. If it's a disease that is going to have a significant impact on daily life, maybe it may result in a total shutdown, then it will naturally reduce the demand for blood. And so the blood transfusion service can focus on maintaining only the emergency required services. But if the infectious agent is such that the disease it is going to cause will require transfusion support, the patients will require transfusion support, then we will be forced to maintain sufficient blood stocks. So accordingly, we have to analyze the situation and plan on what has to be done. So what can be the responses of the BTS to the infectious threat? So first and foremost is to have an early awareness that such a threat is existing. And the information that we get should be an accurate and a reliable information. We should accurately do the risk assessment and identify the possible actions to be taken. And from these possible actions, we must determine which is the most appropriate and proportionate action. Then the action that is decided on should be clearly communicated to all the stakeholders, and it has to be timely implemented. And then we have to do regular planned reassessment of the risk to determine if any changes is needed. And once the threat subsides, all the restrictions that we have imposed can be withdrawn. So the most important line in this was the action that we take should be an appropriate and proportionate action. For example, if there is an infectious disease outbreak occurring in some part of the world, it does not require all blood transfusion services globally to immediately implement protective measures or go into a total closure. That is not warranted. You have to assess the situation, you have to plan, you have to prepare, and you have to execute the plan. Okay, so how do we get this information? So it is seen that only a limited number of institutions and organizations globally have considerable resources which are needed to thoroughly investigate an infectious disease outbreak, identify the infectious agent, perform the required epidemiological studies, and disseminate the information to the stakeholders as soon as possible. So which are these organizations? First and foremost is our World Health Organization. Then comes United States Center for Disease Control and Prevention, then International Society for Infectious Diseases, European Center for Disease Prevention and Control, Global Outbreak Alert and Response Network. So this is the WHO website. So under the international health regulations, it is required from WHO that it trains all its member countries to have surveillance systems which can detect acute public health events in a timely manner, assess and report it back to the WHO, which will help in responding to the public health risk and emergencies. So here, if you see, there is a tab called Disease Outbreak News. If you click on this tab, it will show all the latest disease outbreaks from different parts of our world. So this is the latest from 17 September. That means 2 days back, there was a Marburg virus outbreak occurring in Guinea. So all the latest infectious outbreaks from all over the world you can get from this website. So what are the diseases or what are the infections which will come under this list? So these infections are called as potential public health emergency of international concern, and it should satisfy at least 2 out of the 4 criteria. So the infection should be a public health impact of the event should be a serious one. The event was unusual or is unexpected. There is a significant risk of international spread of the infection, and there is a significant risk of international travel or trade restrictions coming into effect because of this infection. So if any of the WHO member countries identify such an event, they should reassess the public health risk of the event within 48 hours and report back to WHO within 24 hours so that it gets listed in this website. Now, this is the CDC website, and under the heading of Global Health Security also, all these infectious outbreaks are listed. Then another is the Global Outbreak Alert and Response Network, which collects data from all the different government agencies. If we type India, actually 3 agencies from India are reporting to this network. There is the National Center for Disease Control, National Institute of High Security Animal Disease, and National Institute of Virology. Then another is the International Society for Infectious Diseases, PROMED. PROMED is Program for Monitoring Emerging Diseases. This is the largest publicly available system conducting global reporting of infectious disease outbreaks. And during the last 25 years, they claim that PROMED was the first to report on major disease outbreaks such as SARS, MERS, Ebola, and even the Zika virus. So now we have got the surveillance reports ready from different organizations. So, but these surveillance reports look beyond or look at more of the from a public health concern. So our blood transfusion service needs to filter and identify which are the potential threats which might threaten the transfusion services. And this assessment has to be done on a continuous basis. And this assessment has to be actually done on a national level. So each country should have its own blood safety policy. And actually the investment required to start such a program will be minimal because all the information is already available in the online. So if you see, this is an online risk assessment tool, blood safety focused online risk assessment tool, which is developed by the European Union. And here you can quantify the risk of infection transmission by blood transfusion in an outbreak region if you have got certain data available. For example, the incidence of infection in the donor population, or is the donor population, or how much percentage of the donor population is susceptible. If you have all this data, you can actually calculate what will be the risk of transfusion transmitted infections if you collect blood from such a scenario. Another online platform is from the Alliance of Blood Operators. This Alliance of Blood Operators is actually a network of 90 blood operators from North America, Europe, and Australia. And they have also devised a risk-based decision making, which is available only to the member countries. Now, this is the WHO checklist to find out what is the impact on blood sufficiency and safety. So there are a list of questions which we can answer in the form of yes, no, or we do not know, and we can, and the quality of evidence supporting the answers. So the questions are, is this a recognized human infection? Is this a zoonosis? Is the donor population susceptible? Is the infectious agent endemic? What are the routes by which the donor may be exposed? Will the exposed donor come and donate blood? Is there a risk to sufficiency or to blood safety? And are there existing effective donor selection and processing measures in place to identify such donors or remove or inactivate the infectious agents? So these are a set of questions to which we can give the answers and find out whether it will impact the blood transfusion services. This infection will threaten the blood transfusion services. So this is a flow chart from the WHO site in which these questions are listed, and we can give the answers. And if the answers to most of these questions comes as yes, then actually there is a high risk from this infection, and we may have to actually prepare ourselves better. Now, if the answers to most of these questions comes as no, that means the threat is not much and no further action is required. But continuous monitoring and risk assessment should be done on a continuous basis until the threat subsides. So we have two types of disease outbreaks can occur. One is the endemic infections and second is imported infections. Endemic means it is already present in that geographical area. Imported means it has come from somewhere else. So what is the difference? Let's see. So endemic infections, because the infection is already present in that community and now the numbers have suddenly increased. So there is the factor of concern here is that it can have a more rapid spread in the population and it can put a more immediate pressure on the blood transfusion services. But the good thing is that because it is a pre-existing disease, some percentage of our population may have a pre-existing immunity against that disease. And there may be some existing control measures, for example, mosquito control measures already present. Now, if the recovered donors develop immunity, then it is very good. So that there is very less likely chance of our blood stock getting contaminated or this infectious agent getting into our blood supply because most of the donors have developed immunity after they recover. But if this infectious agent is going to present or persist in the body in the form of a chronic carrier state, then the donor may have to be deferred. Sometimes it may require even permanent donor deferral. Next is the imported infections. As I said, these are the infections which are not already present in our geographic area, and some 1 or 2 cases have been imported into our area. So successful importation into the country, into a currently unaffected area requires presence of the means of spreading the agent. That is, you require a vector as well as a susceptible population. For example, the yellow fever has not yet been reported from India, but all the conditions are very favorable. We have got a vector as well as a susceptible population. So if 1 or 2 cases gets imported into India, there is high likelihood that it will spread like an epidemic. So in such cases, when the infection is imported and you have got very less population which is at risk, you can defer those donors who have come from the infected area, who have come from that affected area and has been potentially exposed to these infectious agents. So such donors, we call them as primary contacts. That is the donors who are directly exposed to this infectious agent, either due to travel or residency in the affected area. But one more thing we have to take into account is the secondary contacts of these primary contacts. Secondary contacts are the close contacts or sexual contacts of these primary contacts. Why this is important is because during the last Ebola outbreak and the Zika virus outbreak, the studies showed that this viral RNA persists in the body fluids, especially in the semen, far beyond the viremic period, and it was likely to infect the secondary contacts via sexual contact or through close household or family contacts. So these secondary contacts also have to be deferred for a certain period. And WHO advocates to defer these donors with history of sexual contact or close contact within the last 28 days with anyone diagnosed with Zika virus within the previous 3 months. Next, coming to the vaccination status. So the recently vaccinated donors needs to be deferred for a variable time period, which will depend on the type of vaccination they have taken. So if it's a live vaccine, the deferral period varies depending on the type of vaccine. And if it's a non-live vaccine, attenuated or a killed vaccine, normally no deferral period is required unless the donor has any constitutional symptoms. But all said and done, this is not so straightforward. So if we see, this is from a paper that was published in 2021, very recently, and it has looked at the blood donor deferral periods following COVID-19 vaccination recommended by different world organizations. You have the WHO, US FDA, AABB, our NACO, the Canadian Blood Transfusion Services, everything is listed, and they have got varying deferral periods for the vaccine. So there is no consensus which has been arrived at even after 1.5 years of this COVID outbreak. So what area will you define as an affected area or an outbreak area? So the affected areas are defined as those reporting at least one confirmed locally acquired case within a defined period, which is normally 1 to 3 months. But one thing we have to take care is that the accuracy and reliability of this reporting should be critically analyzed. For example, in poorly resourced countries, they may have limited ability to identify and confirm cases, and there may be limited monitoring of the situation. So there will be significant underreporting of the situation. So for each case reported, there could be many more unidentified cases in the community. So this must be taken into account when using external data to determine travel-related deferral guidelines. Now, we have identified the outbreak area. Now, how are we going to respond to this threat? So first action is we do nothing. We wait and watch. So this is possible in 2 scenarios. That is, the rate of transfusion transmission is minimal compared with the community-acquired infection rate. For example, hepatitis E virus. So usually we do not screen for hepatitis E viral infections in our donated blood units. But in certain special patient groups, hepatitis E screening may be advocated. For example, the immunocompromised, because they might develop a chronic infection. Then second is if our population has got a sufficient pre-existing immunity. For example, parvovirus B19, which is also not routinely screened, but in special populations such as the preterm babies, you can give parvovirus B19 screened blood. Then second action is to cease collections from the outbreak areas. If the outbreak area is geographically restricted, you can cease collection from those areas. That means stop all blood collection activities from that area. Third approach is to identify and defer the at-risk donors. And the usual deferral period advocated is twice the defined incubation period. Fourth and fifth strategy is to advocate screening. You can either go for a specific screening of at-risk donors or implement universal screening. Now, the choice between whether you want to defer a donor or you want to undertake a donor screening depends upon the population which is at risk. So if only a very low number of donors are at risk, it is best strategy to defer those donors from blood donation. But if the number of donors at risk is very high and you cannot compromise, you are not able to maintain the sufficient stocks, then the better strategy may be to go for a screening assays. Now, what type of screening assays will you choose? So most of these infectious outbreaks, they are of acute infections which will resolve very quickly. So if you want to detect the infections, you have to use some tests like nucleic acid testing, which will give you an early evidence of infection. But most of the blood transfusion centers do not have access to molecular screening. So in that situation, you might have to go for a target antigen testing. And antibody testing is of generally limited value because the antibodies appear after resolution of the infection. And by the time the individual is no longer considered to be infectious, even though he is antibody positive. So that is of no value. And the quality of the donor screening assay used is also important. Always try to ensure you use a high quality assay, which will have a very good sensitivity, specificity, and reliability. But the time factor is the most important because most of these infectious outbreaks occur very suddenly and you do not have time to adequately evaluate the assays. So what you can do is to continuous close monitoring of the assay performance is advocated. Now, when you have a screening assay and you find certain donors are reactive for the screening assay, it is always best to ensure the availability of an effective confirmation testing also, and you should be able to give an advice on donor deferral period to these donors. Now, sixth possible action that we can take is the specific pathogen inactivation wherever it is available. But most of the centers do not have access to this, and mostly it is on a research mode. And the centers which have access also, like only plasma and platelet, may be subjected to pathogen inactivation. So these are some of the limitations. And in cases of extreme risk, you may sometimes have to stop all blood collection activities in that area and get blood or support the blood transfusion service with support from outside blood centers. So such a situation occurred during the outbreak of chikungunya in 2005, when they had to collect blood from France. And this is a paper that was published in the Transfusion journal highlighting this situation. At the peak of the epidemic, they had around 1,500 positive cases per 1 lakh donations. They had to stop all blood donation activities and directly procure blood from France. So once you have decided what is the appropriate action that you are going to take, this action must be clearly communicated to all the stakeholders, including the donors, the recipients, and your health professional colleagues also should be informed of this decision, and in any escalation in situation, what you are going to do. This information should be properly conveyed. So for donors, you should always encourage the donors to contact back the blood transfusion service if they develop any symptoms within last 2 weeks following blood donation. If any such donor returns back, then our blood transfusion service should immediately withdraw all the blood components from that donor from the inventory. If any of the blood components has been issued, the patient who has received the transfusion should be appropriately monitored and the investigation should be implemented. This should be communicated to the treating physicians. If any other patient has also received transfusion, that patient you should call back and do the necessary investigations. Now, next coming to hemovigilance. This is a very important thing, and this has to be done on from a national level. So the national authorities should implement a national hemovigilance system, and all blood transfusion services should be asked to register in the national hemovigilance system. This will help to capture and analyze any transfusion associated adverse events and undertake proper investigation to find out whether it is actually a case of transfusion transmitted infection or the recipient had another source of infection. Now, once the outbreak has settled down, then you can withdraw your restrictions. So what is the time point at which you can withdraw your restrictions? So it is defined as a lack of new cases over a defined period, say 3 to 12 months is generally accepted as a measure of end of an outbreak. So by that time, we think that this infection is no longer threatening the transfusion services, and all the donor deferrals or donor restrictions that we had imposed can be withdrawn. So after resolution of infection, the blood transfusion service should sit down and analyze how they managed the outbreak situation, what were the strategies adopted, what were the plans drawn up, and what was the outcome of these actions, and was there any shortcomings or failings identified, and what was done to ensure that these do not reoccur. And any successful strategy should also be documented and if possible introduced into routine practice. And all this should be documented, and the action plan should be communicated to the national and international agencies to help them prepare better for a future outbreak. Now we will quickly see what is the action plan that we can propose based on the risk assessment of threat to blood safety and blood sufficiency. So if we find that the risk is very low, then you need only to monitor the situation, review the existing contingency plans, and include as many options as possible. Try to implement screening if possible, because now you have time, and you can communicate with your clinical colleagues also to identify any suspected post-transfusion infections. If you think the risk is moderate, then you should certainly think of introducing the donor screening assays. You can continue the blood collection activities increase public awareness about the need for blood donation, increase the recruitment activities, and if the situation escalates, you have to prioritize what your blood transfusion service is going to support. If the risk is very high, then you should certainly implement the donation screening, limit the blood usage to urgent or critical cases, and continue with blood donation activities only if you have an option of pathogen inactivation. And meanwhile, also try to explore the option of obtaining blood and components from an external source. And if you think the risk is extreme, then you try to obtain blood and blood components from external sources, continue recruitment activities if and only if you have got pathogen inactivation measures in place and specific donor screening also available, and limit the transfusion services only to the most critical and urgent cases. So this is a final slide. This is from a 2019 Global Health Security Index survey that they had looked at different countries all over the world to look at their preparedness to deal with an epidemic. And as can be seen from this slide, Asian countries require more preparation to deal with an epidemic. And I certainly hope that this presentation will be a stepping stone towards preparing ourselves to better deal with these infectious outbreaks. Thank you for your patient listening. Thank you.
Thank you, Dr. Amita, for your informative presentation. And I think decision-making based on the risk assessment is a skill that all of us need to be practiced. Thank you, Dr. Amita. The next speaker is Dr. Amini from Iranian Transfusion Organization. Dr. Amini is a specialist in anatomical and clinical pathology, and she is a faculty member of IBTO, and she is Deputy of Quality Assurance and Quality Control at the headquarters IBTO.
Excuse me. Yeah, can you switch up your, can you mute yourself? Kiran Goswami. Kiran Goswami, as well.
So you are muted, sir.
Sorry.
Sorry,
As I
sir.
said before,
Yeah, I'm muted.
Yeah, Dr. Amini is Deputy of Quality Control and Quality Management of Iranian Blood Transfusion Organization. Dr. Amini will talk about re-entry of false positive blood donor. Dr. Amini, please.
May I request everybody to mute themselves who are not speaking? There are some background noise. Thank you.
Good afternoon. Good afternoon, everybody. We can speak about the re-entry of false positive blood donors in transfusion medicine. Excuse me. First of all, we want to definition of donor re-entry. That is, three subjects of this definition are very important. A procedure that qualifies a deferred donor as eligible to donate again. Donor reentry procedure may be used following a false positive test result and typically require the passage of time to allow for possible seroconversion prior to the performance of additional serologic testing and NAT. 3 subjects very important. 1, false positive. 2nd, require the passage of time. And 3rd, possible seroconversion should be happen. A deferred donor who donates for autologous use is not deemed to be re-entered and remains deferred until the criteria for re-entry are met. And it is important for autologous donation. Maybe the problem in the change the slide we have. Yes. First of all, we talk about the hepatitis B virus and algorithm for this. According you know very well, HBV is transmitted by blood transfusion more frequently than hepatitis C virus or human immunodeficiency virus. And the residual risk of post-transfusion HBV infection is more than other blood-borne pathogens similar HCV and HIV. And the major cause of HBV transmission by blood is attributable to donations from asymptomatic donors with acute HBV infection in the seronegative window period, or the patients with chronic infections that in which serological markers are not detected, and similar occur to hepatitis B. Seronegative blood donations from infected individuals can transmit hepatitis B, and so the residual risk of this group is higher than other infections. For a re-entry for donors differed because of repeated reactive test result for anti-HBC. According to different tests for HBV, similar anti-HBC, HBs antigen, HBV DNA, the different algorithms are defined for this different situation. If the donors previously differed solely because of repeatedly reactive anti-HBC tests on more than one occasion, it is very important, on more than one occasion, after a minimum of 8 weeks, we can take a new sample from the donors and follow-up sample using HBs antigen and anti-HBC test and HBV NAT. 3 of them are important. If HBs antigen repeatedly reactive or anti-HBC repeatedly reactive or HBV NAT reactive, one of them is enough that the donor is deferred indefinitely. And if all of tests are negative, the donor can be re-entered to the pool donors. But one thing is important, the quality of test kits. For HBV NAT, the test kits should be should have a sensitivity less than 2 IU per milliliters at 90% detection rate. And for HBs antigen should be according the criteria for a screening test for blood donors and similar HBC antibody. Another group for re-entry related to the HBV, the group of donors differed because of repeatedly reactive test results for HBs antigen due to hepatitis B vaccination. This vaccination should be for protection from possible future exposure. Similar, the healthcare worker take vaccine, baby born take vaccine, and another one is a part of an approved source plasma HPV immunization program. So it is not for a high-risk behavior. In this situation, the donor would be eligible for re-entry 8 weeks after the donation that tested repeatedly reactive for HBs antigen and may be confirmed positive by neutralization test. If the blood establishment determines that the donor received the vaccination against HPV infection within 20 days prior to collection of the specimen that tested confirmed positive for HBs antigen, and the vaccination was given solely to protect the donor from possible HPV infection for future exposure to HPV. That means is not now exposed to HPV infection. And all other donor suitability criteria are met when the donor present to donate. So these donors can be back and re-enter in the pool donors for new donations. Third group of the related to the HPV infection, re-entry the blood donors when hepatitis B vaccination was given as a prophylaxis following a specific incident of potential exposure. That means the donors had a high-risk behavior or exposed to a HPV infection. So the donor would be eligible for re-entry after the donation that tested repeatedly reactive for HBs antigen and confirmed positive by neutralization if the blood establishment determines that the donor received the vaccination against HPV infection within 20 days. Similar previous slide. To collection of the specimen. Second one, a follow-up sample collected at least 12 months after the potential exposure. In the vaccination for the protection of the donor, this time was 28, the time was 8 weeks. But for this situation, at least 12 months after the previous sample. And the test non-reactive for HBs antigen, non-reactive for anti-HBC, and negative for HPV DNA. So 3 tests should be done for these donors that we explained about the criteria of the test in the previous slide. One subject is important. A donation that tests repeatedly reactive for HBs antigen should not be used whether or not it is confirmed positive. So every donation that is repeatedly reactive should be discarded. Another subject that we should be should need more attention about it when a donor who is deferred because of previous HBs antigen test result, whether or not these test results were caused by infection with HPV or vaccination or everything, may donate source plasma for use in the preparation of hepatitis B immunoglobulin, provided the current donation test non-reactive for HBs antigen, and the donor is otherwise determined to be suitable. Then another subject, after the HBV DNA started in the blood transfusion centers, and we have some problem about the NAT is positive, HBV DNA is positive, and about the reentry of this group of blood donors. We have two groups. One group permanently deferred and they are not eligible for reentry. Another group maybe they re-enter to pool donors and may be eligible for reentry, but their units should be discarded. For first group, HBV NAT is positive, but HBs antigen in HBs antigen results may be repeatedly reactive and neutralization test is positive and anti-HBC is negative. NAT is positive, HBs antigen repeatedly reactive and a neutralization test is similar, positive, and anti-HBC is positive. NAT is positive, HBs antigen is repeatedly reactive, but neutralization test may be negative, and anti-HBC result is positive and repeatedly reactive. All of them permanently differ and not eligible for reentry. Another group, HBV NAT positive, but HBs antigen non-reactive, or if none is repeatedly reactive, neutralization test is negative. And in this group, related to anti-HBC results, if HBs antigen is non-reactive, maybe anti-HBC positive or negative, and NAT positive, repeatedly reactive, HBs antigen is repeatedly reactive, but neutralization test is negative, and anti-HBC is non-reactive, these groups of donors, the donations should be discarded, but they can re-enter for next donation. After we take a new samples from these donors for evaluation, we must check for NAT and HBs antigen and or anti-HBC. If then HBV NAT, HBV DNA tested with test kits and sensitivity of the test kits is less than 2 IU per milliliters. If this test is positive, HBs antigen may be negative or positive and anti-HBC may be negative or positive. They are not important. Only according to HBV NAT, HBV DNA is again positive, so the donors permanently differ for donation. If HBV NAT negative and all of HBs antigen and anti-HBC in new samples are non-reactive, so the donor may be re-entered in the pool donors and can donate again. Another blood-borne pathogen we can discuss about the re-entry of them is hepatitis C virus. HCV and HIV has some similarity. Means that both of them, each year many donors are deferred from donating blood for an indefinite period because of false positive test result on a serologic test, followed by a negative or indeterminate supplemental test for antibodies to HIV or HCV. After starting the HCV NAT and HIV NAT, another group of the donors are added to this group, and maybe only NAT test is positive. A deferred donor subsequently may be found to be eligible as a donor by a requalification method or process found acceptable. Donor reentry for HCV and HIV, some establishments are used of this reentry, but the algorithm of this procedure is complex and need more concerns about inappropriately returning a donor. In 2010, the reentry of a donor permits prospective donation from a reentered donor who meets donor eligibility criteria, but it does not affect the status of previous collections from that donor. Maybe the FFP in the freezing room. After the donor come back to the pool donors and re-enter, we can't use of this FFP that related to previous donation before returning, and it was a result of positive for NAT or other tests. And similar about the look back. Some situation, the donor differed permanently, and we can return them to the pool donations. One of them is NAT, when the NAT positive and antibody about the HIV is repeatedly reactive, or NAT positive and antigen is repeatedly reactive. Maybe antibody positive and repeatedly reactive test for antibody is repeatedly reactive and Western blot positive, or antibody and antigen, both of them are repeatedly reactive. In these 4 groups, the donor can be re-entered to the for donations. But 3 groups of donors can be re-entered to the pool of donors when HIV NAT result is positive, but it is seronegative, or donors with positive or indeterminate result in the P24. About this algorithm is prepared for the returning the donors with HIV in these 3 groups. According these, 3 tests should be done: NAT and HIV 1 and 2 antibody tests. All of them are negative, return the donors. In other situation, one of them is repeatedly reactive or positive or similar this, they are deferred permanently. About the hepatitis C, 2 groups are not acceptable return if the NAT positive and HCV may be HCV antibody may be repeatedly reactive, or NAT non-reactive, but HCV antibody repeatedly reactive and blood test is positive. Other groups can be returned after testing for more information, and they, according this algorithm, you can see 2 groups can be tested with a new sample for returning to pool blood donors when the NAT reactive but anti-HCV negative, or NAT non-reactive and anti-HCV only repeatedly reactive. In the new sample, the NAT and the 2 test kits for anti-HCV should be done. If all of them are negative, they can return. Other situation, they can't. 2 slides is conclusion of the procedure, not for algorithm or other things. First of all, the best practice. During donor selection, consider a question about the HPV vaccination. So if the vaccinated 28 days before the donation, please defer for 20 days and you have you have any problem about the next donation because after 28 days, they are negative for HBs antigen. And another subject that's solving the problem for reducing the deferral, the donors, is use of the test kits with good specificity. If we use good specificity, high specificity, the false positive will be reduced and donors won't be deferred for this problem. And testing according to quality assured manner. And my last slide about this subject is if we want to re-enter the donors, we need some infrastructure. One of them, first of all, feasibility study about the re-entry. Second one, risk assessment for this problem, especially for court, for legal, and something of this very important. Preparation the algorithm according national and international document, validation the algorithm, approve test kits according standards with the sensitivity for blood donor screening, similar HPV DNA that we had in different slides about the sensitivity of them, validated software for reentry, and good documentation practice for keeping the record of the donors that they are reentered to the donation. And this is my Iranian Blood Transfusion Organization in my country. Thanks a lot for everybody.
Thank you, Dr. Amini, for your comprehensive lecture. We have some questions, then we ask in the panel discussion. The next speaker is Dr. Bhatanagar, an associate professor in Department of Immunohematology and Blood Transfusion in Medical College of Ahmedabad. Dr. Bhatanagar is very expert in quality management and hospital blood banking. She will talk about screening of blood donors from third gender. We are so interested to hear from you. Please.
Thank you. Thank you, Dr. Mahtab. Am I audible? Am I audible?
Yes, yes, we are here.
Yeah, respected chairpersons, Dr. Chaudhary, Dr. Mahtab, thank you for giving me this opportunity to present this challenging topic today. And challenging in the real sense, as I could find very little limited literature on this topic and while preparing for it, and I hope I have done justice to this. Without wasting time, we are already running late. I start my topic. So screening of blood donors from the third gender. I was given this topic by Dr. Chaudhary sir, and I hope I do justice from it. First of all, I would like to talk about some related terms because they are interrelated. Transgender, it is an umbrella term for persons whose gender identity or expression is different from their sex at birth. Gender identity is one's internal understanding of one's own gender or the gender with which a person identifies. Gender expression is a term which is used to describe the people's outward presentation of their gender. MSM here, we all know these days, is men who have sex with men. Cisgender describes a person whose gender identity matches their sex assigned at birth. LGBTQ is lesbian, gay. It's a general term which is assigned to category of the people who are lesbian, gay, bisexual, transgender, queer, intersex, asexual, and gender non-conforming. So coming to donor screening, the top priority, as you know, of any blood center is the safety of the blood donors and the patients. Previously also, my previous two speakers talked about blood safety. In general, what we at the blood centers are aiming at is the basically patient safety and the safe blood products. So all the staff working with the blood transfusion services must be trained to be sensitive to the needs of all the potential blood donors. And the criteria for the donor screening vary from country to country depending upon the prevailing laws and the prevailing, as Dr. Amita has also talked, that the prevailing infectious diseases of the area. So that must be taken into consideration. Now coming to the transgender deferral criteria, there is no international consensus on blood donation criteria for the trans individuals. Many countries, they appear to have a blanket deferral for the trans individuals. The epidemiology and the risk factors vary in the different countries. And some countries, they have still not shared their criteria as of now. So why is the need, first of all, for the deferral for the transgender community? The CDC report in 2016, a guideline was published, HIV among the transgender people, which summarizes information from the US and European countries, which states that many studies, they reveal HIV prevalence rates of 22 to 28% among the trans women in the US and other high-income countries. So we are very much scared. So high-risk group, they come under the high-risk group. So we want to defer them. Again, the MS is a very high-risk group for AIDS when the cases first started appearing in North America in the late 1970s and 1980s. And even later, many studies pointed out that transgender persons, MSMs, female sex workers, persons with multiple sex partners, they come under the high-risk category who could be afflicted with hepatitis B, C, or HIV/AIDS. HIV surveillance report. In this report also, it is a 35-page report in which describes in detail about the behavior among the transgender women and what is the HIV related HIV prevalence in this population. So coming to the global scenario, a few countries I will share. Much work has been done in the USA. So deferral policy in the USA, we go by what is going on in the first world countries. So so we all look up to them for the guidelines. In June 2013, so in general, there was a blanket deferral for the transgender community for the blood donation. But in 2013, the American Medical Association issued a statement calling on the FDA to change the policy, stating that lifetime ban on the blood donation for men who have sex with men is discriminatory and it is not based on sound science. So many activists have come forward that scientific evidence should be there and not a blanket a deferral should be there. So in 2015, the deferral for the lifetime ban was reduced to a 12-month deferral. And later on, based on the research and recent CDC data, now the latest guideline in the US FDA is deferral for 3 months. For the time the person has had last sex with a male. Again, a revised recommendation for reducing the risk of HIV by the US Department of Health, Food and Drug Administration updated on August 2020. Again, it has stated that the questionnaire, the donor history questionnaire in the US, which the blood centers are following, that recommends that it has to be taken, the gender has to be taken self-identified. That is, the Red Cross or any blood center will not question the donor when he or she comes to the blood center about his sex. So the gender will have to be self-declared by the person who is coming to donate blood. In Canada and Australia, the deferral period was decreased from 1 year to 3 months in 2019. In 2000, Australia was the first country to adopt the 12-month deferral, very bold. And in since 31st 2021, Australia again reduced its deferral from 1 year to 3 months. In UK, the Government Advisory Committee, the Safety of Blood Tissues and Organs Committee, stated in 2013 that the risk of transfusion of HIV infected blood will increase if MSM were allowed to donate blood. But it has also changed. In 2017, the UK government reduced the 1 year deferral period to again 3 months, and they said that new testing systems were. Can you please? They said that this decision was based that new testing systems were accurate and the donors were very good at complying with the rules. So that is why they took this decision. Some other countries with the year of implementation: Belgium, Ireland, Czech Republic, a period of deferral is 12 months since the last sexual contact, and the year of implementation 2019. In France, it is 4 months, and year of implementation 2020. Japan, they have decided for 6 months. I think it is safe in 2011, and Denmark again 4 months in 2020. Few countries, again, they do not categorize, the time-based deferral is not there. So sometimes what they do is it is gender neutral. They will just, the high-risk behavior or the sexual contact, the promiscuity, they take into consideration that rather than taking the gender. So again, I got this picture from searching in the net. You can see that the yellow colored areas, Australia, most parts of the Northern America, they have a temporary deferral criteria. Most part of the Eastern Europe, there is no deferral, so no criteria as of now. And the gray areas, as you can see, there is no data as such. Again, this is a blood donation policy for female sex partners of MSMs. Most of the, you can see on the world map, it is a gray area. And in the Eastern Europe and South America and parts of Mexico, there is no deferral criteria as such. Coming to Indian scenario, unfortunately, there is neither any national criteria specific to trans blood donors, nor many studies on the trans population from India. As per the latest guidelines in India, transgender person, men who have sex with men, and female sex workers, they are prohibited from donating blood. The Section 12 of the Drug and Cosmetic Act, subheading H, criteria for blood donation, it bars the persons of transgender, MSM, female sex worker, person with multiple sex partners from donating blood, as they are at high risk for the sexually transmitted diseases like HIV, hepatitis B and C. So even in our country, a petition is filed against this by the transgender activists in March 2021, and stating that they have been discriminated and denied equal opportunity. So I would just like to go through the references which I had come across. This is the one paper I got from 2014, which describes the evolution of policies in the world, global evolution of policies since 3 decades of MSM donor policies in the International Journal of Infectious Diseases. In this article of 2018 in Vox Sanguinis, the authors have reviewed the time-based policies and the gender-neutral policies in various countries. It is of 2018. A good article, good read. In another article I found there, the authors have put the risk associated with these high-risk groups. So what is the evidence? On what basis can we defer them? So that is more research on this has to be carried on. So this is a paper on that. One more recent research, I would say, is going on in the US. It is this advanced study. It is this assessing the donor variability, and it is assessing the donor variability and new concepts in eligibility. It is a pilot study in the target for the MSM. The purpose is to determine if different eligibility criteria for gay and bisexual men can be used at the blood centers nationwide. So it is actually to have more inclusivity, have these transgender community give more equality or give more inclusivity to these people. So a pilot study is done whether for their to assess the high risk behavior. Another study which is from the UK, and 4 UK blood services representatives are conducting this study. It is for the assessment of individualized risk. So this study is aiming at assessing the individualized risk. So it is not gender based, it is assessing the risk individually. So any person who is coming to donate blood, this is a study where they are evaluating the detailed questionnaire on the risk behavior. So more people are now able to give blood. One more recent addition to this deferral policies in Iceland. I got reference from September 14th. Now they had, they had indefinite donor deferral, Iceland, but recently they have proposed a 4-month deferral for all the donors who have engaged in the risky sex behavior. And again, as I told you, they are also following the advanced the study for evaluating their policy. So what is the way forward? For the countries with no or limited data, more research on the risk assessment and deferral periods should be there. The social issues need to be addressed, like more inclusivity and more, gay rights discrimination should be, addressed to. There have to be advocacy groups to ensure that there is no discrimination policies. Finally, the blood centers, they are bound by national legislation. So we are bound by the national legislation as all the blood centers. We need to implement only those criteria or have the donor screening for those people. So we have to follow those criteria. So if we want to include these people in our donor pool, we need to have a risk assessment, detailed risk assessment, and only then we have to weigh the risks and benefits, and we have to assess our blood needs, the blood center needs, the area needs, and so that we can, which will decide whether we want to take this community into our blood donor pool or not. So as Dr. Chaudhary said, there is an upcoming publication which is International Forum on Gender Identification and Blood Collection in the coming issue of Vox Sanguinis, and I think I was waiting for it to get some topic for data for my topic today, but unfortunately it has not yet come out. So with the limited data which I had, I've tried to present the various policies in various countries and whether we need to sort of give a liberal approach to the transgender community or look at our own blood safety. Thank you so much.
Thank you, Dr. Bhatanagar, for your interesting presentation, and keep the time. And now in the panel section, we have a short period of time, and I'm going to this time breaking into some questions. And the first question is from Dr. Prera, faculty member of Colombo University of Sri Lanka. Dr. Prera, we know that Sri Lanka is one of the countries have reached to 100% voluntary blood donation. Yes. And during COVID-19 pandemic, all of the country has dropped blood donors, voluntary blood donors, or blood shortage. and some countries were forced to replacement donor and paid donation and something like that. My question is that what are the strategies we can adopt in blood center to overcome blood shortage and recruitment voluntary blood donation?
Yes, thank you, Dr. Mahatab, and thank you, Dr. Chowdhury, for inviting me to panel this discussion. It is a very interesting topics you have chosen. Right, I am running out of time. I'll go to the question. Right, first of all, that is as a little bit I want to describe our setup. That is, we are nationally coordinated system, what we are having in the country. And this is, there is a main center at Colombo, and there are cluster centers, 24 cluster centers, and that is gathered 101 blood banks. So it is a challenge actually, that is 100% voluntary target is continue in this scenario that is in the epidemic like this. So first of all, what we have done is very close monitoring of the inventory. Inventory management is, I think, other days, what we have done, it is monthly like assessments go on, right? So in this scenario, we formulated an action committee that is to look after the stocks and inventory management team that is under the direct supervision of the director. And so we could assess the blood need, that is as well the collection and the demand also in this scenario we observe that is declining in some areas. Actually, that is some, but the platelet type of components, we could see that is a demand that is still, that is same, right? So, that is close observation in the inventory. As we are having a system, we daily assess the blood need and the stocks. Group-wise, actually, we see the amount of stocks what we are having in the components and the blood in our stock. And that is the first strategy we have taken. And in that way, we could able to distribute and redistribute among our blood banks what we are having in our national pool. That is effectively utilize the components and reduction of discards. That is the first strategy what we have taken. And secondly, that is the camp. You know that our setup, we depend on 85% blood camps and about 15% that is in-house donation. That in-house, that is camp component is the big. So under the prevailing that condition, COVID condition, we face that greatest challenge to how to organize and how to go on to collect blood. That is, national restrictions are there for movements. So against that, we want to gather the people and get the camps done. So that the ministry level, we have given a guideline to conduct, how to conduct camp under this COVID situation. That sometimes it's open air, sometimes we restricted in the organized in the close AC situation, that is AC setups. We avoided that closed environment, and the guidelines prepared, and we applied through collaboration of collaborative effects of other regional health authorities, Health Education Bureau, and mass media. That publication, we could preserve camps to some extent. I'm not going to say that is 100%, but that is very effective. And thirdly, that is the in-house. In-house donation, that is, in-house means that the people are coming to their blood bank and donate. That culture is not in our area actually. That was before COVID, that was about 8%. people who come to blood bank and donate. And with that COVID situation, we could able to increase that up to 15%. That because of strategies what we have taken to improve COVID. One is, nowadays that people are using Facebook, social media. So we use that, and there is a donor, blood donor, that is blood donor feature in the Facebook. That some countries that launch that facility, and hence they can gain a lot of benefits out of that blood donor feature. That is, certain countries entered that launch that, and that is important. So in that way, we could communicate with our donors in an effective manner, because we launched that feature with the Facebook mother company. We liaised with them, and we got that credits, ad credits. That's called ad credits. That help us to boost our Facebook campaign, and our need is published to the people, and they began to communicate with us, and then we could direct them to the close by blood banks. And also other thing is we implement is a hotline, and we publish through this public social media to the people. And so that in-house thing, and that is hotline, through hotline, that is they responded well, and they registered, and that SMS sent to the SMS, and that SMS work as a curfew pass. Those are the basically that I'm running out of time. I think those are the main strategies we have taken to preserve our voluntary system. Now still we are able to keep that stable. Thank you.
Okay, thank you, Dr. Pereira. We have same experience in Iran. We observed a 30% decline in the blood donation, and then with the close monitoring of inventory level, social media, and activated online appointment system and something like that. After, I think, about 5 or 6 weeks, we can overcome the shortage and control the situation. Thank you for your experience. The next question is from Dr. Asavari Bapat, one of our panelists in this webinar. Dr. Asa is a clinical pathologist and vice president of QStar Enterprises. And she has more than 20 years experience in field of transfusion medicine. Dr. Asa, my question is about migration. You know, migration is on the rise these days from in the region or between regions. And I would like to know how you deal with this group of volunteers, and how do you check the eligibility of them? Do you allow them to resident of other country to donate blood in your country?
Thank you so much, Dr. Mahtab. Thank you for the organization and such an excellent, webinar. I'm sorry I had a little flu, so my voice is little this thing, but thank you so much. I think that's a good question, about migration, because as we know, like currently in UAE, we are like the melting pot, because there are a lot of people traveling from, other regional neighboring countries to the UAE. So first and foremost, we don't actually allow anybody else other than people who are holding the residency. So if you have a resident visa, those are the only people who can actually donate blood in the UAE. That's the current status. Having said that, we have had a lot of challenges not just in UAE, but I think in the rest of the world as well, because of the COVID vaccination, all of that. Now, of course, there's a lot of clarity on if you're vaccinated, you can have a self-deferral for 2 weeks. But otherwise, if you have had, let's say, Johnson & Johnson, or currently Pfizer and Moderna are available here, or Sinopharm, you can actually donate blood, or after 14 days to 28 days, depending on whether it's a live vaccine that you have taken. So these are certain challenges that we have faced. The other thing that the local regulations have done is we have a travel declaration form. So even if you're in the school, even if you're in the college, if you have been on a vacation, after coming back, we have to file a travel declaration form where we have to say, have we traveled, any of our close contacts have traveled, all of that. So I think when we look at donor selection from a migration perspective, we have to see that it is a voluntary donation. So the volunteer has to give us the correct information about, did they travel, did they come in contact with anyone. And the other thing that the best part about this part of the world is, because we all carry Emirates ID, and every time we donate, there is information that is stored. So if we go to, because I saw Dr. Roy's question in the questionnaire, that if they go to another another blood bank, they will not be able to donate blood there as well, because that history is commonly linked with all the system currently in place. So these are some of the challenges that we have over here, and I think pandemic has really taught us. I think Dr. Pereira, as he said, it's all about inventory, how you're going to give that confidence to your donors. And I think the other thing that has really proven helpful is the confidential unit exclusion, Dr. Mahtab, because I think that is very important, because sometimes in a camp or sometimes in places, people donate, but they should have that confidence and in the system or in the blood bank to say, if I'm confidential and I don't want this to be utilized. So that helps us to keep a safe transfusion for our patients and for the whole system. Thank you so much. I think if you have any other questions, I'll be happy to say so, but I think this should be all for me. And I think the only thing what I would like to add is, it's better to have a policy for all the blood banks at this point of what you're going to do in future, because I think this has been a good risk assessment strategy for all of us. So I would suggest that. Thank you so much. Thank you, Dr. Mahtab.
Thank you, Dr. Asa, for your answer. In Iran, for the resident of other country, we cannot welcome them because, beyond the vaccination and something like that, we need an ID number, a code of ID number that should be documented, recorded in our software. And without that, for example, other traveler from other country, we cannot welcome them and collect the blood from them. Thank you for your explain about this. And we have some question from Dr. Amini from the audience. Dr. Amini, Dr. Kaylan Roy asked you about detecting a HIV positive. And he asked us, what should we do to this donor? Can you explain us, Dr. Amini?
Thank you. Thank you, Dr. Mahtab. I think about the question about the carrier of HPV.
We have two questions, carrier of HPV and in case of HIV positive.
Yes. About the carrier of HPV, according to the regulation of every country should be considered about the laboratory testing for screening the donors. In Iran, we have HBs antigen and a good donor selection for this problem. So if the donor is carrier, we exclude from donations. And now for screening, we didn't NAT. But some countries, maybe they did NAT for every donations. So according to this, HBs antigen and NAT, they had a special criteria. But totally, if the carrier of HPV infection is identified, can't donate the blood because maybe transfer the infection to the recipient. And about the how we can share the different donors with different blood transfusion centers. I can suggest the National Deferral Donor Registry software in all of centers, in all of the different organizations that they collect the blood. It is the better, the best choice for us for safety. In Iran, according our experience, we are a centralized system for all of the country. We, from more than 1 decade, we share all of the reason and special code of the donors in different blood transfusion centers for the deferral, and National Deferral Donor Registry help to us that if the donor during the deferral period can't donate the blood again. And it is, I think, a good resolution for this problem.
Thank you, Dr. Amini, for answer of 2 questions. And the other question is about MSM, and I think Dr. Nidad explained about the detail. And Dr. Chaudhary, we are running out of time.
Yeah, but you are the boss. You are the boss.
Yeah.
You are the boss, and if you think there are interesting questions, we can keep on going for some time, or else we can stop.
Okay. We have another question from Dr. Batanagar.
Yes.
About the MSM. Can you answer the question briefly? You describe.
You read out.
Yeah, you describe us about the MSM totally, but I would like to know what's your opinion about this group and these changes of deferral totally.
Yeah.
Are they safe or risky?
Yeah. So that is a big question, and I think it's a gray area which we are treating at, and we don't want to dwell into that. But of course, my opinion is that this group of people, definitely we are keeping them at high risk. The whole world is considering them at high risk. So if the countries who have a very robust testing strategies, they may go liberal, they may go forward and have this maybe liberalization of their deferral period, like they may reduce the deferral period to say 4 months or 3 months rather than 1 year. But for the countries like lower or middle income countries where the testing strategies, like for example in India we do not have NAT testing mandatory, so we cannot rely on the other tests like ELISA or the rapid screening test to detect these infections. So definitely in the lower or middle income countries, it is a high risk behavior, and it is good that there is a ban on this community, as we can say. And definitely we have research, we have documents and papers which support that these are high risk people who have risk for HIV and other transmitting diseases, transfusion transmitted diseases.
Thank you. I totally agree with you. And the final question from Dr. Amita. Dr. Amita, given the increased number of infectious outbreaks, we experience COVID-19 and we are worried, are concerned about the future. What will be the most cost-effectiveness strategy to ensure blood safety and sufficiency?
Yes, ma'am. Like we have been learning through this COVID pandemic, and what we have learned is the time is the most important factor. So if we have sufficient time to plan, then our war we can win. So the most important thing that I feel is to have an awareness of what is happening around the world. And we have to, if we have got a very good surveillance system to pick out infections, which have the potential to become into a large-scale infection, then we can prepare accordingly. So that I think the surveillance systems has to be strengthened, and the reporting system. So I'd request all the blood transfusion services to have a national hemovigilance system in which they can register, and any untoward incidents they can report. And the public health people, they can have a good surveillance system of any disease outbreaks, which can also be reported to a national platform, so that that information gets disseminated to all the stakeholders. So that, I think that is the most important step which will help us in this fight, because this emerging infections is going on, will continue. So we cannot stop it with one infection. So this is a war which is to continue. And in this war, only this awareness is going to help us to win this war and prepare for the situation.
Okay, thank you for your summarized answer. And time passed quickly, and we have to end of the panel. Many points of view delivered and many messages